जैसे आपको ये दिख रहा है ना, ये स्क्रीन,
एक सेकेंड सर। हाँ सर।
ये स्क्रीन जो है ये आपके मोबाइल में आता है।
अच्छा।
ये लिंक्स है, मैं आपको ये लिंक शेयर करूंगा। उसके बाद आपको ये प्लेलिस्ट दबाना है।
ओके।
जैसे आप ये प्लेलिस्ट दबाओगे आपको इस तरह का प्लेलिस्ट पूरा दिखाई देगा सामने।
ठीक है सर।
फिर
और ये
आप
जो
इसे चूज
इसमें
कर
10, 15 और 1, 5 ये जो लिखा आ रहा है, ये क्या लेक्चर नंबर्स हैं?
कितने कितने लेक्चर्स किसमें हुए।
अच्छा अच्छा।
ये अपडेटेड नहीं है,
हाँ हाँ,
अभी
नहीं नहीं
थोड़ा
सर,
वो
वो
है।
जस्ट फॉर इन्फॉर्मेशन।
टोटल नंबर ऑफ लेक्चर्स अप टिल नाउ इज 230।
230। यू प्लान टू कंटिन्यू देम, लाइक वो क्या, इट्स लाइक अ साइकिल, एक बार खत्म होगा फिर नया शुरू हो जाएगा ऐसा?
नहीं, अभी तो हेमेटोलॉजी चल रहा है, इसके बाद हम लोग डर्मेटोपैथोलॉजी स्टार्ट करेंगे। और एक और हम लोग करने जा रहे हैं, उसमें आपका भी हमको हेल्प लगेगा। वो वी आर स्टार्टिंग अनदर सीरीज परस्यू के साथ कॉल्ड रीकैप।
अच्छा
Recap is recent advances in cytology and pathology.
अच्छा।
Because recent advances का एक पेपर होता है।
हाँ, एक रिसेंट एडवांसेस का पेपर होता है।
So we are now trying to get in all these senior consultants to ask their final MD people to take one lecture on any recent advanced topic of, like in hematology or in transfusion medicine or in nephropathology, uropathology, anywhere, on a recent advanced topic. And we will try to assimilate all of them in one place,
ओके।
so that all the MD and these what you call DM students as well as the PDCC students, they can access these recent advanced topics in one go. So we will try to contact people who are the heads and departmental seniors in various colleges and ask them to ask their PGTs to take a topic which, and they will guide that PGT, so that then it all becomes in one place. Because recent advances is something which everybody wants to hear. They have been sending us messages कि please take lectures on recent advances.
मुझे एक लगता है ना सर, हमारे रेजिडेंट भी अक्सर बोलते हैं कि छोटे छोटे जैसे आधे घंटे के ना वो टेस्ट, लैब टेस्ट एंड टेक्निक्स पे भी होना चाहिए, समथिंग वेरी शॉर्ट एंड फोकस्ड, कि आधा घंटा बस उसी टेक्निक के बारे में बात करी। और अभी इनफैक्ट ये जो बच्चे डीएम एग्जाम देकर के आए थे तो वो बोल रहे थे कि मैम हिस्टोपैथोलॉजी टेक्निक्स पे इतने सारे क्वेश्चंस थे, जो कि
हाँ,
वाज
that's a good
आल्सो
idea.
अ काइंड ऑफ इग्नोर्ड एरिया।
Yes, yes,
तो
it is. It is.
वो छोड़ देते हैं कि ये तो टेक्नीशियन का काम है।
Yeah.
मतलब
I think
थोड़ा ब्रॉड इंफॉर्मेशन
वो भी
रहता है।
करेंगे.
वो भी
That's a
मतलब
good idea. वो कर
there
सकते
must
हैं.
be so many techniques in, मतलब there are so many techniques in histopathology and I'm sure same
Yeah.
applies for hematology.
Yes.
I don't know sir, आपका अभी आफ्टर कोविड थोड़ा पार्टिसिपेशन कम हुआ लोगों का, नहीं कुछ असर आपको नजर आया?
Participation in the sense live audience.
नहीं, लाइव तो सर इस प्लेटफॉर्म पे पहले भी हमने देखा था, मत नहीं है, बट मतलब आफ्टर, जैसे आप बोल रहे हो ना रात में देखते हैं अक्सर लोग, तो क्या
नहीं,
नंबर्स
बहुत
अभी भी
ज्यादा है.
मेंटेन है?
या
अच्छा।
या बहुत ज्यादा है.
ओके।
वो बहुत today only we got the YouTube this year's review.
ओके।
So I'll just I'll send you on the WhatsApp. I don't want to share with everybody
हाँ हाँ,
because
श्योर सर।
I don't want too much of publicity on that. Just for the sake of knowledge, I'll just tell you in 1 second. We have had 1.1 million watch time minutes, 1.1 million,
ओके।
and 126.8 thousand total views in this
ओके।
1 year. So
Oh,
that's
that's a huge number, I would say.
yeah, that's a huge number, and it is all across all the continents, UK, US, everywhere. So we are good to go. Are you ready?
Yes, sir.
So fine, just give me a minute. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 17E, which is malignant myeloid diseases. We are streaming live from SGPGI Lucknow via Kolkata. A very pertinent and interesting topic, and a very competent person to speak on that. The topic of the day is acute myeloid leukemia, where we'll be dealing with the classification, morphology, flow, molecular, prognostics, and risk classification. And to talk on that, somebody who is a very well-known hematopathologist, Dr. Ruchi Gupta. She's an MD from the famous PGI Chandigarh. Presently, she's an additional professor, lab hematology in the Department of Hematology at the famous SGPGI Lucknow. Her areas of interest is malignant hematology, MDS, AML, MM, benign hematology with thalassemias and bleeding disorders, with multiple publications in national and international journals. Before I ask Dr. Gupta to start, let me request all of you to keep your mic muted, your camera off, and please do not share your screen. With this, let me request, ma'am, please share your screen. Let's start.
So is my screen visible?
Not yet.
Not yet. But
Just
I
press that
have,
arrow.
so I've
Press it
pressed it
now.
has become, so it's now not, I'm not able to press it again.
Okay, so I think you need to just again come log out and log in.
Okay.
Right. So just press that arrow and yeah, that's your screen. I can see it. Yeah, please make it full screen. Yeah, perfectly fine, ma'am. Please start. Thank you so much. You are muted. I think you're muted. Dr. Ruchi, you're muted. Just unmute yourself, please. On the bottom side, you will see the.
Am I audible now?
Yes. You can stop your video so that it's in sync.
Yes, sir, I think I've done that.
No, you
I'll just
haven't.
cross check again. Yeah.
Yeah. Now, please share your screen. Yeah, make it full screen, please.
Okay.
You're perfectly fine. Please start. Thank you.
Thank you, sir, so much for your kind introduction. I actually started doubting how you're talking about me. So today I'll be talking about acute myeloid leukemia, and it's like all in all about the classification of AML, the present WHO 2016 classification, which is currently being practiced, and the prognostic risk stratification in AML. So needless to say that AML is a very heterogeneous disease and has numerous genetic aberrations, and we really need to classify this disorder in a way so that it gives us more prognostically and clinically relevant information. A large number of systematic diseases have been carried out to identify the genomic landscape of AML, and they have identified a catalog of genes which are altered in AML. So this has helped us to identify many newer disease subsets in AML which can affect the clinical management. They are providing us new prognostic information, and they are also generating information for targeted therapy. So for a disease like AML, we need a classification that will clearly define the different categories or the groups. They should be clinically distinct. Their prognosis, those which have a similar prognosis will have to be, grouped together because they will respond well to the standard 3+7 therapy. Whereas those where we know at the molecular level that they are having adverse genetic aberrations, they need to be taken up for hematopoietic stem cell transplantation after the first CR. Plus, besides doing all this work, the classification should also be open to incorporation of newer information that is getting added on daily by these NGS techniques, whole exome sequencing, whole transcriptome sequencing, and so on. So it should be capable of undergoing refinement. The initial attempts to classify AML started way back in 1976 when this French American British cooperative group came together, to classify this group of disorders. And this was largely based upon the morphology and cytochemistry, and they divided AML into these 8 subgroups based upon the morphological features, whether it is an undifferentiated or whether there is some degree of maturation, whether it is a promyelocytic leukemia or a AML with monocytic differentiation, and so on. So this classification was largely based on morphology. But gradually, as things evolved and people realized that there is more to AML than just the morphology, and different genetic abnormalities can lead to, within the same subgroup, they can have a different outcome. So that led to the revision of this classification, and this armamentarium, has guided and helped. Where initially we were stuck with just morphology and cytochemistry, then gradually karyotyping, real-time PCR, quantitative techniques, microarray, whole exome sequencing, whole transcriptome sequencing, targeted sequencing, and so on. So all this, testing added a huge or a lot of information to existing knowledge of AML, and that compelled us to revise what was used previously. And gradually, what we have is, poor thing for resins. Luckily, 2001 में हम लोग, we used to learn around 4-5 groups of AML. Then it got revised in 2008, and then subsequently again in 2017. All the newer entities which are getting discovered, and when larger studies are being done on these molecular mutations, so people are able to define ki, okay, so if this is an MPN1 positive AML, so it will perform like that, and if it is an FLT3 ITD mutated AML, the prognosis is going to be bad. So gradually, as studies are being done and these recurrent genetic abnormalities are getting identified, they are getting incorporated into this classification. So till very late I remember, even I think I finished my MD, I used to wonder इसको recurrent को recurrent क्यों बोलते हैं? What do you really want to say? What does this mean? What does this term mean? So recurrent, if you know, if you understand, is that is something which is disease defining. अगर 15-17 translocation है तो APML है, मतलब that is it, that is done. So those mutations which are disease defining mutations are usually known as the recurring genetic abnormalities. So जिसको पहले से पता था, you're really bright, और जिनको नहीं पता था, so I have added on something to that, knowledge. So if you see from 2001 to 2016, it was for the first time in 2001 that besides morphology and cytochemistry, immunophenotyping and cytogenetics and clinical information was used for classification of AML. Subsequently, in 2008, as I said, that we had more information available on the different mutations. So we had provisional entities like mutated NPM, provisional entities. Mutation in the SEPA gene became added as another mutation entity, and gradually more and more emphasis is now being laid on the molecular biology besides just the cytogenetic and immunophenotypic finding. So the same pillars of classification have continued in 2016, and we realize that just mutated SEPA will not really have a prognostic relevance unless it is a biallelic mutation. Mutated NPM became a more definitive category than just being a provisional, and other mutations like RANKS1, etc., came to become now as a provisional and a well-defined entity in the present day classification of WHO 2016. So it also leaves the scope open for further modifications, and as newer mutations are being identified and they are able to group that TP53 positive AMLs and those which have abnormalities in the RNA splicing gene, they might perform badly. So gradually, as our understanding about these mutations increases, we'll probably have another version of this classification in the subsequent years. So if we look at the basic model of leukemogenesis, it's just to represent a heterogeneous population of cells in a bone marrow. But what happens is that suddenly one particular population of cells has some proliferation advantage. What is this? Basically, these are signal transduction mutations or the class 1 mutations, which are usually involving the tyrosine kinase domains of the FLT3, NRAS, KRAS, TP53, KIT, or BCR-ABL1, which leads to an increased proliferation of an abnormal clone of cell, and also additionally in the class 2 mutation, which is usually affects the transcription factor, there is an impaired differentiation. So what is happening in AML is, I think I need not spell it out, that what is happening, that but the blast cells basically have an enhanced proliferation capability because of these signal transduction mutations, and this is supplemented by another class of mutations where there is a maturation block. So though that results in an accumulation of immature cells in the bone marrow. So this class 1, class 2 has now become slightly vague, and because of so much of the genomics which has come in, there are many more classes and complementation groups which have been identified in AML. So this in 2013, a comprehensive characterization of the AML associated variants was done by the Cancer Genome Atlas Research Network, and they identified 200 clinically annotated adult de novo AML cases by whole genome sequencing, whole exome sequencing, methylation studies, RNA, microRNA sequencing, and they said that there are a number of driver mutations, that is those which are relevant for pathogenesis, and passenger mutations which lead to the AML pathogenesis. I just wanted to go back to my car and stress that within this heterogeneous population of or rather a homogeneous, apparently homogeneous population of cars, there is one subclone. So similarly in AML you have a founding clone and you have some passenger clone, which over time what can happen is that this clone might subside and another newer clone might become preponderant. So AML, even overtly, when it looks like it has one particular kind of a mutation, it is actually harboring many clones of cells which can become dormant or active over time after therapy. So this was a result of the meta-analysis by Eli Papimenol in 2016, where they showed that approximately 20% of the AML have fusion gene abnormalities, the 31% have aneuploidies, and a major chunk, that is 46%, are cytogenetically normal and actually have a load of gene mutations. So, and this is a Circos plot which is depicting the relative frequency and co-occurrence of the genetic alterations in AML. This is just to emphasize that though this is the distribution of the genetic abnormalities in AML, they are not like watertight compartments. Fusion genes can transcript and can be found to coexist with numerous genetic abnormalities. And even at the molecular level, if you see, this arc is representing that NPM1 is one of the most frequently mutated gene in AML, and frequently it co-occurs with FLT3 ITD, DNMT3A, FLT3 TKD, and so on. So there is co-occurrence of these mutations in AML. So this has been studied by carrying out whole exome sequencing and variant allele frequency to identify smaller clones of cells also, where they came to know that besides one particular driver mutation, additional passenger mutations are also present in the same patient. So all this information, was used to derive a genomic classification of AML. This is one of the landmark papers of Papimenol, and they took 1,540 patient samples from 3 prospective trials of patients of AML who were undergoing therapy. And what they noted was that they noted 5,234 driver mutations in 76 genes or genomic regions, and 2 or more driver mutations were seen in 86% of the patients. And in fact, I must that statement, at least one driver mutation was present in more than 96% patients, and 2 or more driver mutations were present in 86% of the patients. So, despite identifying such huge number of mutations, following the current WHO classification, 50% of the patients could not really be classified into any of those categories. So, based on this information, they proposed their own genomic classification, which seemed to be more relevant in terms of clinical outcomes and in defining different patients of AML, which could not be classified by the existing WHO 2016 classification. So this is the tabular or the table where they have depicted the genomic classification. So though they have retained what is there in the current WHO 16, like in version 16, 15, 17 and translocation 821. So AML with NPM1 mutation was the most frequently present subgroup of AML. Then they had another important subgroup where there were mutations in the chromatin genes and in the RNA splicing genes, or both. Then they had newer groups like AML with TP53 mutations and chromosomal aneuploidy, because this group particularly fared very badly and was frequently associated with complex karyotype. Then this is what is already there in the current WHO, biallelic, SEPA, MLL, and so on. They also proposed a group where AML with IDH mutation was there. And then further, in cases where there was no driver mutation, but detected some class-defining lesions, then AML with detect where there was no driver mutation, and finally AML meeting criteria for more than two genomic subgroups. So all these initial slides I've just compiled, and there's much more information which can be added to this. But the bottom line is that AML is a very heterogeneous disease. It has some driver mutations, it has some passenger mutations, and these mutations coexist at variable number. They can coexist in number of patients. They can be founder mutations which become dormant over time, and a subclone can become more important. So with all that, that is end of my theoretical part of the class and what all is there about the current WHO classification, and what all genomics has the scope to add and refine to this existing classification. So coming back to what currently we are practicing and classifying. So in the subsequent slides, I'll be discussing what we do routinely in our reporting when we come across a case of AML. How do we take clues from the morphology and the phenotype and link it with the genetic findings? So this is a 2016 WHO classification, which is currently dividing AML into 6 subgroups: AML with recurrent genetic abnormalities, AML with myelodysplasia related changes, myeloid sarcoma, myeloid proliferations associated with Down syndrome, therapy-related myeloid neoplasms, and if you have nothing from above, then this is basically an AML NOS that is not otherwise specified. So the class with recurrent genetic abnormalities has numerous aberrations like translocation 821, inversion 16, PML, RARA, MLL rearrangements. So I was lucky. हम लोग जब पढ़ते थे तो ये initial 4 थी, फिर 2008 में और 2 ऐड हुई, फिर और 2 ऐड हुई. So I really pity the students, but this is what you have to keep updating yourself as and when this classification gets revised. So I'll go over these entities one by one with the examples from our routine reporting. So how do we approach a case of AML? One of the very important components is the clinical presentation. Is it a short history? Was there a preceding history of MDS? Is it a child? Is there organomegaly? Are there chloromas? Is there facial dysmorphism? You suspect that this is a case of Down syndrome. Is there history of therapy for other malignancies? So then accordingly, this history has to be integrated with morphology. Morphology starts from the basic peripheral smear examination, the blood counts, the bone marrow aspiration, morphology, cytochemistry. Usually in AML, it is defined that the blast count has to be more than 20% in the peripheral blood or the bone marrow, except in cases where you have recurrent cytogenetic abnormalities like translocation 821, 15, 17, or inversion 16. In these cases, you can have blast even less than 20%. So when I look at the smear, this is how we see what are you looking at. A blast is a blast. So जो undifferentiated blast होता है ना, वो typical चाय समोसे की शर्त वाले होते हैं कि it is a blast. What next? Is it looking like a myeloid blast? Is it large? Is the chromatin opened up? Do you have nucleoli? Is there cytoplasm? Do you have granules? Do you have odd rods? If these features are not there, then probably we are dealing with a M0 category, or it might even turn out to be a lymphoid blast by flow cytometry. When we talk about, and this would then correspond to the AML M0 or the minimal AML with undifferentiated AML basically. Then next, if you see maturation and it is less than 10%, it goes into the FAB AML M1 or with minimal maturation subgroup, and so on. Like for M2, you will have definitely more than 10% maturation, and there are other features which will help you to guide whether it is associated with translocation 821 or any other specific genetic abnormality. I don't think I need to spell out details about abnormal promyelocytes. An abnormal promyelocyte is an abnormal promyelocyte. It is a medical emergency and has to be recognized. Then you need to see if your blast is looking like a monocytoid cell or is it showing blebbings, and you should suspect a blast of the erythroid lineage or a blast of a megakaryocytic lineage, and so on. So I'll be covering some of these entities in the subsequent slides. So once you are done with the morphology and you know that you are dealing with a case of acute leukemia, probably acute myeloid leukemia, you do your immunophenotyping, then you need to supplement this with cytogenetics, FISH, RT-PCR to see whether there is associated recurrent genetic abnormalities like 8, 21, 15, 17, 122, 9, 11, etc. so that you can just stratify this group of patients into good or intermediate or adverse. Further, when you are done with this, then you need to do is the molecular workup to further refine, especially if your cytogenetics is normal, then that will become as a cytogenetically normal or a normal karyotype AML, and then you further need to then go ahead and do a molecular workup. Currently, NPM1, FLT3, ITD, SEPA, RUNX1, and KIT. These are the 4-5 mutations which are almost mandatory or strongly recommended to be done to prognosticate your patients of normal karyotype AML so that they can be treated or managed accordingly. If you have the facility or the feasibility of subjecting your samples to NGS, there are numerous platforms which are available, myeloid NGS panels available, which will do up to I think 56 or more genes, and they'll tell you what all other things are mutated in AML. But the relevance of not all of them is established till now. So coming up to the example of the first, that is AML M0. So as I said, a blast is a blast where I talk to my resident and say कि पता नहीं क्या निकलेगा. So this is a more better picture जिसमें पता नहीं क्या निकलेगा. You have a basophilic cytoplasm. It could even be an L2 like morphology, and it could even be an M0. So M0 cells are usually undifferentiated megakaryocytic leukemias, acute undifferentiated leukemias, or even a leukemic phase of a high-grade lymphoma should be ruled out by immunophenotyping. So IP becomes mandatory for diagnosis. Usually AML M0 blasts are positive for the immaturity markers like CD34 and HLA-DR and 117. And there is a high frequency of apparent expression of CD7 and TDT in patients with AML M0. And in such a morphology where your MPO etc. are negative, frequently MPO would be negative even on cytochemistry. So you really need to look carefully that your cyto CD3 and 19 etc. are also negative, so that there is no possibility of a mixed phenotype acute leukemia. So WHO has clearly defined the lineage. For an AML or a myeloid blast, either the cells should be expressing myeloperoxidase or they should be exhibiting monocytic differentiation, and at least 2 of the following markers like 11C, 1464 lysozyme should be positive. I still remember NSC के लिए we used to approach Dr. Pratik कि हमारा लग नहीं रहा है, इसको please लगा दीजिए, but gradually because of the invent of flow cytometry, the use of NSC has gone down, but it is a very, very beautiful stain which highlights the monocytic population. For a T cell, cytoplasmic CD3 is the mandatory requirement, and for B cells, you have a combination of CD19 and at least one of the following like 79A, cyto CD22 and CD10. Or if CD19 expression is weak, then you need a strong expression of the following markers. So this table, should be, in and out. नींद से उठा करके भी कोई पूछे तो आपको ये बातें पता होना चाहिए कि usually you do not call anything as a myeloid leukemia unless until it is MPO positive either by cytochemistry or by flow, or you are showing a monocytic differentiation. But yeah, in AML M0, your MPO can be negative, and then we take the help of 1333 and 117 and HLA-DR. Like in this case, when we did flow cytometry, we have gated the red population is the blast or the cell of interest, which is DIM 45 as compared to the mature lymphocytes. I assume that majority of the population, or the students, know how to interpret a flow dot plot. And the blasts are positive for 34. There is a heterogeneous expression of 117. They are again immature, so 34 and HLA-DR is positive. So here in this case, your MPO is negative. So, but when MPO is negative, you also have to ensure that your cyto CD3 is negative, your 19 is negative, your B cell markers are negative. And when in these situations, when 117, 13, 33, 34 HLA-DR are positive, then we can comfortably call this as a case of AML. And beside this site scatter 45 plot is a very important plot. It gives you a lot of information. Like you can see that there is almost no maturation, and majority of the population is the blast. So this was another case. Again, majority of the population is blast. You have no maturation, and I've highlighted this case because there is something in between the blast and the lymphocytes. Had we been live, I would have loved to ask you a question. What do you think this is? But since it is not the situation, I'll help you out and I'll tell you that this population is actually basophils. Again, it is quite frequent to see MPO negativity in case of CML blast crisis, or in patients of MDS who have progressed to AML. उनके blast भी काफी छोटे होते हैं and frequently MPO negative होते हैं. So this is actually this is the position of the basophils, and the basophils, as you can see, they are expressing 117, but they are negative for 34, and they are also expressing 33 and CD11B. Whereas this is clearly the population, the red one is clearly the population of the blast, which is expressing HLA-DRN 117, 34, 13, 33. And then there is some DEM-MPO, so we can call it a case of, if it was a de novo case of AML, I'll call it AML, or if we know that there was a preceding history of CML, then we'll call it a myeloid blast crisis in a case of CML. Okay, so ये case इसलिए भी लिया था just to highlight that frequently you have CD7 aberrant expression in the myeloid blasts, and this is considered to be a poor prognostic marker. So M1 doesn't really have any specific features, ऐसे बहुत important entity नहीं जिसके बारे में बात करी जाए type सही है. So but ये है कि it has some degree of maturation, and so usually MPO is positive in M1. You will have fine granular positivity, but the maturation is usually less than 10%. Immunophenotypically, again, they will be positive for the standard markers which are seen in any other AML. M2, an entity which is close to my heart. बहुत मजा आता है M2 देखने में, to see that you have maturation, you have OR rods, you have eosinophils, you have dyspoisis. So 821 positive AML makes up almost, I think, a major chunk of the Fab AML M2 class. It's heterogeneous in the terms that within AML M2 you have a lot of other abnormalities which can coexist, and KIT mutation, if it is positive, then that in addition, it's though translocation 821 is said to have a good prognosis, if there is a coexisting KIT mutation, especially in the adults, that confers a poor prognosis. So there are clues in the morphology of Fab AML M2 or AML with maturation which tells you that this case could probably be harboring a translocation 821. So some of the features which you need to look for in a case of AML with maturation to see कि translocation 821 है कि नहीं है, उसमें आता है presence of OR rod in the maturing myeloid cells, though it is really very uncommon. Rather commonly you will get is very long thin OR rods, and these Golgi region HOFs, eosinophilia. In fact, dyspoisis is one of the very, very important features and seen in almost 90% of those M2s जिसमें कि 821 आता है. Eosinophilia, and if you have mast cells, then you need to really work up for KIT mutation. So, and this has a bimodal presentation, less than 20 years and more than 60 years of age. Because of the dyspoisis, you can be misled and you might start thinking of MDS with excess blast. But let me tell you, इस तरह के long thin OR rods जो होती हैं MDS में usually नहीं मिलती हैं, और MDS के blast अक्सर छोटे होते हैं, cytoplasm कम होता है, and उसको myeloid blast बोलने के लिए भी आपको काफी मेहनत लगती है. So AML M2 is a very heterogeneous group. It can be positive for translocation 821. Further, if it is, you need to see whether KIT mutation is present or not. क्योंकि translocation 821 अपने आप में अच्छा है, लेकिन but if you have coexisting KIT mutation, then it has a bad prognosis. Then rarely this AML M2 or translocation 821 positive AMLs can also be seen in cases of systemic mastocytosis with additional hematopoietic non-mast cell disorders. So, sorry, this group of diseases also fares badly, right? Immunophenotypically, let us see what do we have. So, even the basic site scatter 45 plot is telling you that besides the blast, which are here in the bottom, you have a good going degree of maturation. Then your blasts are positive for 34, 117 and the standard myeloid markers. Here you can see that there is aberrant expression of 19. So besides the morphology, even immunophenotype हम जब देख करके भेजते हैं वहां पर flow के लिए तो हम पूछते हैं 19 आया क्या? So whenever we start suspecting the presence of translocation 821, these are things which we ask for. And agar CD expression of CD56 has been shown to correlate with KIT mutation, it's not an absolute correlation, but yes, if it is there, you should definitely screen for 56. But if it is not there, इसका मतलब नहीं कि नहीं screen करना है. So in the diagnostic armamentarium, besides the biopsy, you can do a RT-PCR to show the presence of this fusion transcript, or you have cytogenetics where you can see that the long arm of chromosome 8 is getting translocated here at chromosome 21, courtesy Dr. Manish. He's established the cytogenetics lab in our department. So besides this translocation 821, we have additional 21 chromosome over here. So besides translocation 821, this group of AML also shows numerous other cytogenetic abnormalities like deletion 9, loss of Y, and loss of X are very frequent, though they have no prognostic relevance. And there is controversial role of trisomy 4. Some say it has a bad prognosis, while some say it has a good prognosis. So this fusion transcript can be identified using FISH as well. So coming to the next class or the next group of AML, that is, I don't think I need to say, it is apparent that this is a case of APML. You have PHAGOS, very strong MPO positivity, and this is the microgranular variant where you usually have a apple core like morphology, very few granules, and usually this correlates with the BCR3 transcript. Your TLC would be very high, and otherwise usual जो classical APMLs होते हैं, they usually present with pancytopenia, and you have to look for these leukemic promyelocytes in such patients. Clinically it is important these patients come as DIC. जब resident marrow करके आता है वो बोलता है मैम sample aspirate करते ही clot हो जा रहा था. So sometimes the residents who are smart वो वहीं से suspect करते हैं कि हम कहीं APML से तो नहीं deal कर रहे हैं. So APML is a medical emergency. The moment you suspect, you have to start ATRA. And then you send your sample for molecular workup and confirmation. But if you are on morphology, if you are seeing and suspecting APML, please communicate it to the clinician immediately. Right? In fact, we even go to the extent we call the patient अगर वो चलता फिरता आया था कि आओ भाई admit हो जाओ तुमको really need to treat you. Then beside, though APML has a very good prognosis, but certain mutations like FLT3, if they are present with APML, they do confer a relatively adverse prognosis. And by immunophenotyping, if you look at these cells, अभी next plot में दिखाती हूँ, so usually they are 34 and they are negative. Presence of CD2 and CD56 has been shown to correlate with adverse prognosis and presence of FLT3 mutation. So flow, if you ask me, हम लोगों ने flow अपने यहाँ पे भेजना बंद कर दिया because we are seeing morphologically we are suspecting it. Then we rather send the samples for molecular diagnostic rather than for flow cytometry. But when we used to do flow cytometry, this is how the plots look like on side scatter and CD45. You can see since the cells are very granular as compared to the population of blast जो अब तक low side scatter में थी, now this population is standing. And this is same either for microgranular variant or the classical hypergranular variant. Microgranular variant में actually microgranular इसलिए होता है because submicroscopic granules होते हैं, but they are there. So when they are interrogated by the laser on a flow cytometry machine, they scatter a lot of light, and this is how they appear. So they are positive for 1333, they are negative for HLA-DR and 34. Frequently 117 can be positive or negative, and even 11B is negative. 64 can be positive, but this kind of plot is usually not indicative of monocytic. So 64 का presence इसमें does not indicate that it is a monocytic leukemia. For the apple core or the microgranular variant, AML M5 sometimes becomes a close differential diagnosis, but if you do a cytochemistry, even that will clearly tell you that this is probably APML and not M5. So again, doing FISH will give you a result within 24 hours, and this was from a case which had an abnormal morphology. We suspected कि APML लग रहा है, but besides 1517, there are other genetic partners which are known like 517, 1117. And it is important to identify these transcripts because they will not respond to ATRA एंड इनको स्टैंडर्ड 3+7 कीमोथेरेपी हमें देना पड़ेगा. वो एक ही सांस में बोलती जा रही हूँ मैं भी. आई थिंक आई शुड टेक अ ब्रेक. So coming on to AML with monocytic differentiation, you have to know how a monocyte looks like, how does a immature monocyte looks like, how does a pro monocyte and a monoblast look like. So ये हमारा frequent discussion lab में होता है, मैम ये pro monocyte लग रहा है कि monoblast लग रहा है कि क्या लग रहा है. So frankly speaking, a pro monocyte, is something which, in my opinion, is a relatively larger cell as compared to the mature monocyte, as a slightly opened up lacy chromatin and presence of 1 to 2 nuclei, whereas a blast has a relatively more round contours and the chromatin is supposed to stay lacy, and nobody can describe what kind of chromatin is lacy. You have to learn to appreciate that. And besides, the cytoplasm is pale grayish blue and usually has a lot of vacuoles. So these atypical monocytes are also seen in JMML and CMML. But whenever you see a case of JMML, when you're suspecting a case of JMML, बच्चे का peripheral smear देखा, I still remember एकदम excite होकर कि ma'am, I think we have seen a case of JMML periphery में that 14% monocytes and they are looking abnormal and there is occasional basophil. And पूरा रात भर बैठकर resident ने JMML पढ़ लिया and next day she went to do a marrow and it turned out to be an AML with monocytic differentiation. So you really need to do a marrow in these cases, and I think AML with monocytic differentiation still is much more common than JMML or CMML for that matter. So अगर marrow में monocytes दिख रहे हैं तो peripheral blood में monocytes दिख रहे हैं तो you really need to go and have a look at the marrow. क्या पता it has actually more than 20% blast and it is actually a case of AML with monocytic differentiation and not a MPN or MPN MBS overlap category. This is also one thing which I feel is close to, ये मुझे बड़ा मजेदार लगता है कि monocytic leukemias are usually present with higher counts. They have organomegalies, hepatomegaly, splenomegaly. Since the cells tend to, clutter at the end and they, look like eggs to me. मतलब hairy cell leukemia के जैसे हम बोलते हैं ना fried egg appearance है because of the cytoplasm. This is the kind of feeling which I get if I see a smear in low part which has this look. I start suspecting that I'm looking something which has a monocytic differentiation. So at a closer look, you can see that these are like the monocytes, but if you see these have a relatively opened up chromatin and deep lips. And though I really cannot appreciate the nucleoli, but these are looking more like promonocytes. Whereas so that is likely to be a case of AML M5. Whereas in M4, if you see, you have a combination of cells. You have at least 20% cells with myeloid lineage and their precursors, and at least 20% monocytes. इसमें frequently you will have monoblast kind of cells. You will have some pro-monocytes. You will have myelocytes, metamyelocytes, some polymorphs, some dyspoises, and some of the blasts are showing or rod. So that tells you that you actually have a mixture or a dual population of cells over here. And this comes out very nicely on flow cytometry also. Again, the basic site scatter CD45 plot, if you see, in an AML M4, where you have a combination of cells, you have a distinct population of blasts and a separate population of the monocytes. Monocytes जो होते हैं usually lymphocyte के सर पे बैठे होते हैं यहाँ ऊपर. Whereas if you have a pure population, that is, or rather M5, it will either be a monoblastic or something which is like pro-monocytic. So the position is also different. ये monoblast वाले जो होते हैं वो more in the blastic region होता है. Again, there is no maturation. Whereas here you can appreciate that there are maturing myeloid cells or granulocytic cells. And this is probably again M5B kind of a thing where you have more pro-monocytes. इसीलिए ये वाला बटन जो है पूरा का पूरा lymphocyte के सर पे बैठा हुआ है. And besides the routine markers like 1333, usually 33 is the brightest on the monocytes, and we frequently see that 34 might be negative in these cases. 117 is positive, 33 is bright. 33 bright is a feature of usually monocyte. It is brightest expression of 33 is on the monocytes actually. Then you have HLA-DR, then you have 64 and 4. However, 14 is negative. So 14 negative is suggestive that these cells are precursor monocytic because mature monocytes usually 14 positive होते हैं. 64 जो होता है वो throughout the lineage present होता है. And these monocytoid cells can be positive for 123 and 56 as well. Yeah, I have time. So, if you see a case of M4EO, meaning thereby that you have a combination of myeloid blast and some monocytic cells and monoblast, and like along with that you have a lot of eosinophils and abnormal eosinophils with abnormal granulation, you should start suspecting presence of inversion 16. And this is one of the cases again where besides inversion 16 there were also another other cytogenetic abnormalities, and this is just to reflect that inversion 16 is really difficult to identify on the karyotype. I had to go back to Dr. Manish and ask him, "क्या mark करा है तुमने?" So I picked up this diagram from the net to explain what is happening. There is inversion 16 में. This could be pericentric or paracentric, is what he told me, and there is an inversion of the 16th chromosome, and so you can see that इस वाले में तो यहाँ कोई band नहीं है, but here you have a band. So that is how you interpret that there is inversion 16, and additionally there is additional 21 chromosome and additional chromosome 22. And this is how your flow plots, as I said, would look like. So your monocytes are negative for 34, whereas your blast population is positive for 34. Usually monocytes जो होते हैं वो dim 30 MPO दिखा सकते हैं, whereas there is some degree of heterogeneous 79 है, पता नहीं क्या कर रहा है in these cells as well. So this was a case of AM4EO, where in you picked up clues from the morphology to identify that whether this could be a case of inversion 16. So additionally, I would like to point out that even translocation 911 also frequently has morphology of M5. M6 has now become almost like a very rare entity. हम लोग पहले कभी diagnose कर भी लेते थे because in the initial 2008 WHO they had given an option of erythromyeloid leukemia where myeloid blast could also be seen along with pro-erythroblast. But now in the revised WHO 2016 classification, more than 80% of the population should be erythroid, and out of these more than 30% cells should be pro-erythroblast. So eventually हम बहुत सारा जब ये proliferation देखते हैं, या तो हमारे माइलॉइड ब्लास्ट ही आ जाते हैं 20% से ज्यादा फ्लो पे, या अगर 20% से कम रहते हैं then it becomes like a case of MDS with excess blast 2. And this picture I have borrowed from the WHO, that these dyspoitic, or rather these pro-erythroblasts frequently show a dot block PS positivity. This is an old case where these are probably some of the pro-erythroblasts, and more than 80% of the cells should basically be of the erythroid lineage. And immunophenotypically, if you see, they'll be positive for glycophorin, E-cadherin, CD1, कुछ और ऐड करना होगा शायद, CD117 and CD36. And frequently they have a complex cytogenetic abnormalities and have a poor outcome. Coming on to almost close to the end of the session. So this is a case of AML M7. Again, you have to take clues from the morphology. This blast nucleus looks like that of a megakaryocyte, or that homogeneously purple condensed clumped chromatin, and presence of these cytoplasmic blebs. Frequently AML M7 may be dry tap आएगा because these blasts tend to release PGIMER etc., and resulting in a lot of fibrosis in the bone marrow. So these cells are usually negative for PAS and MPO, and you might get micromegakaryocytes also in the bone marrow aspirate smear. You need to do a flow cytometry to confirm the lineage of these cells. And whenever you see a case of AML M7, it will, before you label it as an AML NOS, you should look for recurrent abnormalities like translocation 122. You should know that whether the child is a case of Down syndrome or not, because more than 50% of the AMLs in Down syndrome are AML M7. Then you should rule out AML with myelodysplasia related changes. So the NOS variant can be present both in the pediatric as well as the adult population, though normally the ones with translocation 122 are seen more commonly in the pediatric population. So argyromegaly and I just said dry tap are frequently seen. This is how a flow dot plot would look like. The blasts are usually almost negative for CD45, MPO. When all lineage markers are negative, cyto CD3 नहीं आ रहा, MPO भी नहीं आ रहा, 79A भी नहीं आ रहा, so then you need to actually add to your panel CD36, CD41A and CD42. Even CD9 is positive in the megakaryoblast. So this will help you to identify the lineage of these cells. And 41, 42 जो होता है, it is recommended to carry out cytoplasmic staining rather than surface staining. There is a high frequency or tendency for aberrant CD7 expression even in the megakaryoplasts. So this is another case, cyto CD41 positive, CD9 positive, CD117 positive, and CD33 positive. So in cases, especially if you have a history that there is some facial dysmorphism, or there is a you should suspect when you see a case of megakaryoblast, you should rule out the possibility of underlying Down syndrome. There is almost 150-fold increase risk of AML in patients of Down syndrome as compared to the normal population at that age. 50% of these present at less than 5 years of age and are of megakaryoblast lineage. They may or may not be preceded by TAM, that is transient abnormal myelopoiesis, which usually manifests within the first 3 months of life. It is almost indistinguishable from AML M7. It is just that if it undergoes spontaneous remission, so probably it was a TAM, and 20 to 30% of these patients might subsequently progress on to develop AML. So besides presence of translocation, presence of additional 21 mutations in the GATA1 gene are considered pathognomic of TAM or Down syndrome. Uh, so this is another case of AML, and time for a cup of tea, and this is the nuclear invaginations, which gives this look of a cup. This is frequently seen in cases with AML NPM1 mutation. And again, a blast with almost no maturation. They are frequently associated with M0 or rather M1 type of morphology. And MPO is nicely positive, and 117 is positive. Frequently, these NPM1 mutated AMLs are 34 and HLA-DR are negative. Okay, separate plots में. So 34 is negative and HLA-DR is negative, whereas rest of the myeloid markers are positive. So there is a very good concordance of seeing this morphology of a cup and detecting an MPM1 mutation by fragment analysis, or even immunohistochemistry is available. These cases are usually those which have a normal karyotype, and this is how we do NPM mutation testing in our lab by fragment analysis, which is usually a 4 base pair insertion. Normally हमें खाली ये wild type का peak मिलना चाहिए था, but when there is additional NPM1 mutation, this is another fragment which is there. This case had both NPM1 as well as FFT3 ITT mutation. If ITT mutation में multiple internal tandem repeats होने की वजह से you have two different sizes of fragments which are picked up by this fragment analysis technique and will guide you. So initially khali FLT3 ITT ka presence was considered as a bad prognostic marker, but subsequently people are now realized it is only if you have a high allele burden. So how do you calculate this high allele burden? High allele burden is if you take the ratio of this abnormal peak to the wild type. If it is more than 0.5, it is called as high allelic burden, and that is now supposed to correlate with bad prognosis. Another provisional entity, that is the AML with BCR-ABL1 translocation. Before you move to this entity, you should really be sure that there was no preceding history of AML. This is not a case of MPAL. Usually these patients have less splenomegaly and basophilia, but the two cases which we recall, which I could recall reporting at our center, in both the cases we suspected the presence of BCR-ABL1 because of the presence of basophilia. And at the molecular level, again, like CML, P210 transcript is the most frequent, though other additional abnormalities like loss of 7, trisomy 8, complex karyotypes are frequently seen. And other AML-associated mutations which are not seen in myeloid blast crisis CML are also noted in this group. So if it is an MPAL, and with translocation 922, so it will not be classified over here. So before you label it as AML with BCR-ABL translocation, you have to rule out these 2-3 particular things. So this was again a case of AML 821 which relapsed, and at that time it showed extensive basophilia, which compelled us to think why are there so many basophils. हमने kit भी करवाया था, but additionally we could see that there was fusion transcript both for 821 as well as for I can't really make out, but yes, it was positive for both BCR-ABL1 as well as 8 translocation 821. And we picked this up only at the time of relapse when there were blasts and there were presence of these abnormal basophils. So this category is also supposed to have a poor prognosis as compared to other AMLs. And again, AML with myelodysplasia related changes, you will have dyspoiesis in at least 2 lineages. 50% of the lineages should be affected. You have pseudo-Pelger-Hue polymorphs over here. You have a lot of blast, and as I keep saying कि MDS type वाले blast जो होते हैं वो थोड़े छोटे होते हैं, blue cytoplasm होता है, and usually MPO negative होते हैं. Then there is some degree of dyserythropoiesis, and these are micromegakaryocytes. If you see, they are almost the size of a promyelocyte. So what are the differential diagnoses? If you see myelodysplasia or if you see dysbiosis in the case of AML, you should rule out that there is no therapy-related AML. You should see if there is any basophilia, then it could be associated with translocation 6-9. Dysbiosis with basophilia, eosinophilia, and micromex is also a feature of inversion 3 or translocation 3-3, where there is deregulation of MECOM or GATA2 expression. And AML with MRC-like features can also be seen in 25% of NPM1 positive AML. So besides all these, in fact, even translocation 821 में भी काफी significant dysbiosis मिलती है, but वो usually myeloid में रहती है, megakaryocyte और erythroid lineage में dysbiosis कम मिलता है. So, but occasionally it has also been reported. So these are the diagnostic criteria which have been laid down by WHO, more than 20% blast, and any of the following, like history of MDS or past history of MDS basically, or if you can show the presence of MDS related cytogenetic abnormality besides the multilineage dysplasia, and there should be absence of prior cytotoxic or radiation therapy, and you should rule out that there are no recurrent cytogenetic abnormalities. So this is again from one of our cases where we had this kind of a morphology, dysbiotic megakaryocytes, and the cytogenetic evolution revealed loss of chromosome along in deletion of chromosome 5q. Oh, so with that we are almost at the end of the lecture. I just have 2-3 slides more. So with all that information, you know, what you have derived, इतना सारा cytochemistry or immunophenotype or genetics करके, you know, what eventually you are trying to do is to prognosticate the cases, these cases. And this is the ELN 2017 classification, which is currently being practiced, wherein these recurrent genetic abnormalities like 821 inversion 16, mutated NPM1 without FLT3 ITD or low FLT3 ITD mutation, and biallelic mutated SEPA are considered as good prognostic factors, whereas in the adverse you have translocation 6-9, variable MLL rearrangement 922, inversion 3, deletion 5q, complex, RUNX1, etc., etc. There are a lot of mutations which are also reported in AML which have really not found their place in this current risk category, but they have been shown to perform badly to standard chemotherapy, and majority of these are associated with a normal karyotype or a cytogenetically normal AML. So among these what we should know is ASXL1, IDH mutations. IDH mutations का थोड़ा controversial है, but TP53, then MIR155, these are microRNAs which have been shown to be associated with adverse prognosis. And if we, you know, sometime later in the subsequent years resort to the genomic classification which was proposed by LFF and Menol, then they have shown that there are 11 subgroups, you know, they which are defined on the basis of these recurrent genetic fusions or cases where you have no genetic fusions but you have molecular mutations like SEPA, IDH1, chromatin spliceosome group, etc. So there they have shown that this classification helps you to better define the prognosis of patients of AML. So in the end, you really need a combination of things to reach the diagnosis of AML. And sometimes, you know, you can have this grandmother-like look in the sense that ये वो भेड़ की खाल में भेड़िया, you know. I remember seeing this case, but this is once in a blue moon, once in a, you know, maybe 10 years that we saw this case where we had blasts with our rod, and this rod was also MPO positive. But when we did immunophenotype, the cells are negative for 45, so these are blasts. उसमें तो कोई googly नहीं है. They are positive for 34 and 38, but they are, you know, negative for 13. They are positive for 117. They are positive for 33 HLA-DR, 7 and 56. So 7 and 56 are poor prognostic markers. 25 negative. Surface CD3 is negative. And 4-8 negative, 1A negative, but so you see MPO is also negative, Cyto79A is negative, but even on repeated staining, we could appreciate a dim Cyto CD3 over here, and MPO was consistently negative. So we plus this patient, if I'm not mistaken, had a mediastinal mass, And so we were compelled to give a diagnosis of ETPALL in this case. This was reported by us, and there are very few such case reports. This is not, it should not probably really be the last slide. मुझे मनीष ने बोला मैम आप क्या बताना चाहते हो ये लास्ट स्लाइड बता के, तो मैं कुछ नहीं बताना चाहती. I just want to tell you that you should be aware that there are so many morphological variations, and you really need to supplement the immunophenotype and the molecular information, before you actually define what particular leukemia it is. Among the molecular currently recommended ones are at least NPM1, FLT3, ITD, SEPA, RUNX1, BCR-ABL1. And then you have the facility of NGS, then you have like TED2, ASXL1, etc. And a long list of genetic abnormalities which can be seen in AML, but the clinical relevance of some of these is yet to be established. And so with all this, we are actually moving towards, a more individualized or customized therapy gradually when we start identifying like FLT3 ITD mutation is, so, and IDH1 mutation is. So we have specific, drugs for targeting these so that we can improve the survival of these patients with poor cytogenetic abnormalities, or, in that patients who are falling in that risk group. That is our team. That is myself, then Dinesh, Dr. Heman, and Manish. And these are the two people in the molecular lab who are dealing constantly day in, day out with such a huge load which we have at our center. So with that, I come to the end of the talk, and I'll be happy to have any questions. सर आप हैं वहाँ पर?
बिल्कुल हूँ.
इतना सन्नाटा था मुझे लगा कि
very nice presentation. Just to stop presentation दबा दीजिए ताकि आपको स्क्रीन बंद हो जाए. Right, great. Very nice, very crisp, and very to the point. Absolutely fluent, like always.
Thank you, sir.
Good. Dr. Dinesh Chandra says excellent and very informative talk. He has a question. He says, those centers who don't have facilities of flow cytometry, how should you approach a case of acute leukemia with morphology and cytometry?
So those centers where flow is not available, I would say that cytochemistry is a very important tool. At least in majority of the cases, if you are a good morphologist, you would be able to identify the cells, like M0 ko chhod do. But if you have M1, maybe you will have MPO positivity, then you have M2. And as I said, ki M2 mein, so there are so many clues which tell us now we have, a good positive predictive value of combining all those features, जिसमें हम, morphology देख के बोलते हैं इसका sample भेज दो ये 821 आ जाएगा. So you have to learn to recognize these abnormalities. Then you have M3, M4, M5. So at least these categories, you really don't need immunophenotyping, and you can, support by morphology and cytochemistry alone. But I must say that unless until you actually supplement that information with immunophenotype and cytogenetics, तो आपकी growth रुक जाएगी. You will really never be able to learn more beyond morphology. And because of the availability of all these techniques in our center, I really feel that my knowledge has increased in the past years to recognize many newer entities, and to at least do a triage. The centers जिनके पास ये facilities नहीं है, at least they can identify कि हाँ ये poor prognostic category का लग रहा है, या ये 821 लग रहा है, ये अच्छा prognostic है. They can at least guide the patient that they should go ahead for further workup and so on. और बाकी का question तो मुझसे department में पूछिए.
Yeah, that's right. Adil Aziz Khan says very informative talk, ma'am. Yeah. The only thing I need to add here is that transfer of technology also requires transfer of samples.
Yes.
So long as you know that this is your limitation, you can always transfer that sample to some other higher center of higher activity, and they will be able to guide you. It's
Yes,
the
sir.
ignorance which brings in all the confusion, and maybe along with ignorance an element of ego. Why should I share this with that? I think for the patient's benefit, it's always good to share. And now with this advanced courier programs, all this can be shared. Everything can be shared across. So
Yes, sir.
all
And
centers
gradually,
across.
sir, when I was talking to Dr. Pratik, he was telling me now that the cost of NGS and everything is coming down. because
Yes.
when we outsource the service, they have a huge load of samples gradually, so they are able to cut down the cost. So, but starting the same thing at our own center, we find it difficult to, bring it to a comparable cost. So we also, even being a tertiary care center, जब हमें मतलब, we feel the need, and if the patient is affording, we really do send out these samples for NGS. बाकी yes, जो basic panel है, जितना हम लोग को जो recommended है by WHO, except for a few things, majority of those are being tackled in-house, and we also have cytogenetics lab. And yes, that is now required. The need of the day is that if you have a clinician who's asking for it, then you will have to provide it.
That's right.
So, so that is there.
Yeah, and if you know, then you can guide your clinician as well.
Right, sir. So, like many of our residents are naturally, all the residents are not able to, move to centers like, all tertiary care centers. But what we feel good is that at least, we train them in a manner that they learn to identify what we are identifying. And so that, they can guide and the patient in a timely manner to an appropriate center, as you rightly pointed out. So, this emanating this knowledge is important, matlab, you get to know and gradually, build up on your own knowledge and keep yourself aware.
Yeah, I think that's one of the goals of our platform also, because you are reaching right from Northeast to Kanyakumari to Kashmir. So people out in many places are not being, everybody cannot access Dr. Ruchi as a teacher. So you are teaching everybody, you're teaching the country. And Dinesh, would you like to ask something here, or you would like to ask in the department privately?
जब मैं सीनियर हूँ वो ज्यादा पूछ नहीं पाएगा.
फिर मैं भी सीनियर
But
हूँ.
yeah, frankly, if there is
No, no.
anything you would like to discuss, Dinesh, or add on, I think it'd be good.
हाँ दिनेश, you can unmute and ask. Yeah. डरो मत.
No, no. Good evening, everyone. So, actually, this is really very informative and very simple talk, and whatever we see in day routine reporting, that has been beautifully explained. So, there is, I think, most of the things I have already highlighted in the talk or has been already discussed. So, I think this is time to move on, at least to flow cytometry and molecular. We are cannot just by cytometry and morphology we can say it is acute leukemia. That's all.
Yeah.
So, I again thank you, ma'am, for such a wonderful talk.
Thank you, Dinesh.
Right. And I would also like to thank Dr. Ruchi for such a wonderful, crisp, and simple talk. And before we close down, I would request you to share the PDF. We have a system of uploading all the PDFs on the Google Drive, so that everybody has access to information which is free and open to all.
Sure, sir.
Thank you so much, Dr. Ruchi Gupta, for taking out time from your busy schedule and coming here on this platform and teaching us.
My pleasure,
I
sir.
think we have another lecture sometime in the end of January or something.
Yes, sir.
We'll welcome you back again there. Thank you so much. Take care. Good
Thank you,
night.
sir.
God
Good
bless you.
night.
Bye-bye.
Bye.
Bye. Bye.